Hi everyone, welcome to our module on hemostasis and thrombosis. Before beginning with the video, I would like to request all of you to please like the video and subscribe to the channel. This lecture series is provided free and is open access for everybody. If you find it useful and wish to support its development, you can pay us with the link that is on the screen that's also pinned in the description with any of these payment methods. Firstly, let's begin with understanding about hemostasis. This hemostasis is the body's mechanism to stop bleeding after vascular injury while still maintaining normal blood flow in the rest of the circulation. This hemostasis has two main components: primary hemostasis, which forms the platelet plug, and the secondary hemostasis, which stabilizes the uh, plug with fibrin. Although we describe this primary hemostasis and secondary hemostasis separately, in reality these processes happen simultaneously. This primary and secondary hemostasis happens simultaneously. Primary hemostasis forms a temporary platelet plug. There are four main steps. First one is transient vasoconstriction. The second step is platelet adhesion. The third step is platelet activation and degranulation. And the final step is platelet aggregation. So the entire process depends heavily on platelet receptors and 1 millibrand factor. So this 1 millibrand factor is nothing but a factor that's essential for platelet adhesion. Immediately after injury, the vessel constricts. So this is mediated by neural reflexes and endothelin that is released from the endothelial cells. The purpose of all this is to reduce blood flow and allow the platelets to interact with the exposed subendothelium. So this step of exposure and interaction of platelets with the exposed subendothelium is temporary, but it's the most critical and crucial steps for initiating hemostasis. When the vessel wall is damaged, collagen is exposed. Platelets bind directly to collagen via GpIIa 2A receptor and to 1 millibrand factor via the GP1B receptor. 1 millibrand factor acts as a bridge between platelets and the vessel wall. Clinically, whenever there's a defect in the 1 millibrand factor, it can lead to 1 millibrand disease, which causes impaired platelet adhesion. Once platelets adhere, they become activated. They change shape and release mediators like ADP and thromboxane A2. ADP binds to P2Y12 receptors that are located on the platelets, and this ADP binding with the P2Y12 receptors amplifies platelet activation. And this amplification in turn recruits more platelets and prepares them for aggregation. The final step of primary hemostasis is aggregation. The activated platelets express GP2B3A receptors, and whenever the activated platelets, once expressing these GP2B3 receptors, they bind fibrinogen, which and this fibrinogen acts as a bridge between the platelets, and more platelets aggregate together, bind with one another, and finally forms a primary platelet plug. But it's still unstable at this stage. So this stabilization happens once secondary hemostasis gets into effect. Secondary hemostasis stabilizes the platelet plug. This is done through the coagulation cascade, which leads to fibrin formation. So once this fibrin is formed as a result of the entire coagulation cascade, it reinforces the pre-existing platelet plug and forms a stable clot. So we divide this into intrinsic and extrinsic and common pathways. So this coagulation cascade can be divided into intrinsic and extrinsic pathways, which finally come together at a common pathway. The extrinsic pathway is triggered by tissue factor and involves factor 7. Tissue factor, factor 7, it's measured by thrombin time. So the intrinsic pathway is activated by surface contact activation, and this involves factors 12, 11, 9, and 8 in the same order. So 12 first gets activated, and this in turn activates 11 into 11A, and this 11A activates 9 into 9A, and this 9A activates 8 into 8A, and this 8A finally enters the common pathway. So this intrinsic pathway is measured by the aPTT, activated partial thromboplastin time. So these relationship between PT and the extrinsic pathway and aPTT and the intrinsic pathway. So these are very high yield exam concepts and need to be remembered. Both the intrinsic and the extrinsic pathways converge at the common pathway. So the key factors that are involved includes factor 10, 5, 2, and 1. Factor 10A converts prothrombin to thrombin, and then this thrombin converts fibrinogen to fibrin. Both PT and aPTT are used to assess the common pathway. Factor 13 stabilizes the clot, so it forms crosslinks between the fibrin strands to form a strong and a durable clot. Also remember that calcium and phospholipid surfaces are required. Calcium and phospholipid surfaces are required for coagulation. Now let's discuss about the natural anticoagulant mechanisms. The body prevents excessive clotting using natural anticoagulants. These includes antithrombin 3, protein C, and protein S, and the fibrinolytic system. So all these mechanisms and pathways ensure that clotting remains localized at the site of injury. Antithrombin 3 inhibits thrombin and several other clotting factors. Its activity is significantly enhanced by heparin. So that's why heparin works as an anticoagulant. So that's the reason. That's the reason why heparin works as an anticoagulant. It inactivates multiple clotting factors like thrombin, factor 10A, factor 9A, factor 11A, and factor 12A. Now let's discuss about protein C and protein S. Protein C is activated when thrombin binds to thrombomodulin. So this activated protein C along with protein S, it inactivates factors 5A and 8A. So this activated protein C along with protein S as a cofactor, this in turn inactivates factors 5 and activated factors 5 and 8, and this in turn leads to uh, limit the clot formation. Fibrinolysis breaks down clots. So the key enzyme that is involved in this fibrinolysis is plasmin. Tissue plasminogen activator. We all know TPA or tissue plasminogen activator. So it's something that converts plasminogen into plasmin. Plasmin and this plasmin finally degrades fibrin and fibrinogen, dissolving the clot after repair. When fibrin is degraded, D-dimer is produced. So D-dimer is nothing but an example of fibrin degradation products. It is a marker of this D-dimer is a marker of active clot formation and breakdown. Clinically, this D-dimer is used to evaluate cases of DVT, pulmonary embolism, and disseminated intravascular coagulation. Thrombosis is abnormal clot formation inside intact vessels. So, unlike hemostasis, this is harmful and this can also obstruct the blood flow. The main concept that's involved in thrombosis is something that's called as the Virchow triad. In Virchow's triad, there are three main factors. The first one is endothelial injury, the second one is abnormal blood flow or stasis, and the third one is hypercoagulability. So, this triad of endothelial injury, stasis or abnormal blood flow, and hypercoagulability, endothelial injury, abnormal blood flow, and hypercoagulability. This triad explains most of the cases of thrombosis, and this triad is called as a Virchow's triad. Whenever there's damage to the vessel lining and leading to endothelial injury, this promotes platelet adhesion and clot formation. Whenever there's stasis, this leads to abnormal blood flow. This abnormal blood flow in turn leads to accumulation of these clotting factors at a particular place and predisposing the blood or the circulation to get thrombosed. Hypercoagulability, whenever there's increased tendency to form clots, this hypercoagulability gets into effect. This endothelial injury, abnormal blood flow, and hypercoagulability, all these three main factors, as a virtuous triad, they finally lead to thrombosis. Some patients have genetic conditions that increase clotting risk. The most important ones are factor V lead-in mutation, prothrombin mutation, and antithrombin deficiency. So some patients have genetic conditions that increase clotting risk. The most important ones are factor V lead-in, prothrombin mutation, and antithrombin deficiency. The most common, so this factor V lead-in mutation is the most common inherited thrombophilia. Factor V becomes resistant to protein C. This leads to increased clot formation and increased risk of deep vein thrombosis. Prothrombin mutation increases thrombin production, whereas antithrombin deficiency causes inhibition of clotting. An important point is that heparin doesn't work well in antithrombin 3 deficiency. So whenever there's mutation in the 3' untranslated region, there's prothrombin mutation, and this leads to increased prothrombin levels, and this finally leads to increased thrombin formation. So whenever there's more and more thrombin, this leads to uh, more and more clot formation, more and more stabilizer clot formation. This leads to promotion of thrombosis. Whereas whenever there's antithrombin 3 deficiency, there's reduced inhibition of clotting factors, and this leads to excessive clotting formation. And whenever there's reduced antithrombin 3 heparin that's given exogenously, that becomes ineffective because it requires antithrombin 3 to function. So this together, prothrombin mutation and antithrombin deficiency, both of these things, when put together, it can lead to uh, increased clotting tendency. Now let's discuss about antiphospholipid syndrome. So this antiphospholipid syndrome is an acquired hypercoagulable state. It causes thrombosis and recurrent pregnancy loss. So whenever there's a woman who is presenting with recurrent pregnancy loss and also history of DVT or right calf pain or left calf pain, whatever the question mentions, just think about antiphospholipid syndrome because that's most probably a pregnant woman. Whenever the patient is mostly a pregnant woman, the first thing that has to come to your mind is antiphospholipid syndrome. The associated antibody is the lupus anticoagulant. A key paradox is that PTT is prolonged in vitro in lab tests, but patients actually clot more. So, clinical significance of this antiphospholipid syndrome is that patients with unexplained clots and recurrent miscarriages, you need to think about antiphospholipid syndrome. Now, let's quickly summarize the entire module. Primary hemostasis involves platelet adhesion and aggregation. This adhesion happens via GP1B1 Willebrand factor interaction, whereas this aggregation happens via GP2B3 receptor binding with the fibrinogen. The secondary hemostasis forms the fibrin via the coagulation cascade. Intrinsic pathway is measured by aPTT, and extrinsic pathway is measured by prothrombin time. Uh, Anticoagulants regulate clotting and fibrinolysis breaks clots. Antithrombin-free, protein C, and S. So these are the anticoagulants. So they regulate clotting, whereas TPA, tissue plasminogen activator, this TPA converts plasminogen into plasmin, and this plasmin in turn leads to breakdown of fibrinogen or fibrinolysis, leading to formation of fibrin degradation products. And one of those examples is D-dimer. Vacho's triad explains thrombosis. So the so Vacho's triad consisting of endothelial injury, hypercoagulability, and blood flow abnormality like hemostasis, and also endothelial injury, hypercoagulability, and abnormal blood flow. This constitutes the Vacho's triad, and this predisposes the patient to thrombosis. And finally, uh, factor V lead mutation leads to resistance to protein C, and APS causes antiphospholipid syndrome causes thrombosis despite prolonged PTT. So this is the end of the lecture on hemostasis and thrombosis. We'll be right back with a third video continuing the hematology series. Thank you. Bye.